Good morning and good afternoon to you all. My name is Jennifer Majori. I am the Executive Director for NAPT. For those of you who do not know who the National Association of Proton Therapy is, we are a mission-driven organization of 54 proton therapy providers. We are dedicated to increasing patient access to proton therapy through advocacy, education like this, and research collaboration. And we will work very closely with our member centers, our industry partners like IBA, and policymakers to advance this field to ensure that the patients who need this care can receive it. So this is an example of collaborating with our corporate partners to deliver education to you all. This is a recorded webinar, so you're welcome to access this and share this with your peers at a later date as well. Because we have a shared mission with corporate members like IBA and Proton Therapy Academy, we're able to offer these frequently. I encourage you to go to our events website to look at other upcoming webinars. Do want to remind you that this is a no endorsement organization, so this is for educational purposes only. But as many of you all know, these are also kept in connected community. So if you're a member of NAPT, you have access to all of these recorded webinars. So today's webinar is a very important topic. Operational efficiency is key, especially as we are reaching a level where more and more patients are shown to have, there's evidence, research showing the support for these patients to receive proton therapy. It's very important that we make sure we have access. And part of that is utilizing our current centers to optimize the clinical workflow. And that's what you're going to hear about today. So we have IBA, the Proton Therapy Academy, here with us today to talk about real-world strategies for optimizing treatment efficiency. So I want to introduce Frederic Janine. Many of you know him. He's an ambassador to Proton Therapy Academy, but of course, key to IBA in many of their initiatives. And so he will be introducing the panel today. And want to thank you all for your continued support. Just a reminder, there is a Q&A box, so I encourage you to place your questions in there. Frederic will get to that and moderate a discussion. You can put those in throughout the webinar as well. And we'll be able to manage some of those question and answers at the end of the presentations today. So Frederic, without further ado, I'll turn it over to you.
Okay, good morning for the people in the US, good afternoon for the people in Europe, and good evening for anyone that's joining from Asia. Jennifer and NAPT, thank you so much for the introduction. I see that a lot of people are connecting and so on and so on. So we are way above 100 now, so I'm sure we're going to get a great attendance. And with that, I'm going to take control of the slide deck. Courtney, am I good now? Yes, I am good. So again, hello to everyone. Super excited to be here with you today with the help of NAPT. And we're going to talk to you about efficiency today. I'm going to be introducing the webinar of today, and then I will leave the floor to Andrew Wroe from the Miami Cancer Institute and Dr. Simone from the York Proton Therapy Center that will also give their perspective on how they've improved the efficiency and the workflow of their respective proton therapy center. Okay, so that's me, that you already know. So why have we launched the Proton Therapy Academy initiative? And I want to highlight 5 essential parameters that we felt drove this. The first one that everyone has experienced over the year, and this is an NAPT driven graph that shows the evolution of the patient, not only in quantity, but also in case mix. And you see that both are increasing in quantity and in complexity, which drives for further efficiency. Increasing evidence. I mean, we always refer to the oropharyngeal cancer care, where 16 institutions came together to create those data that has known, that has reached the conclusion that IMPT is a new standard of care option for patients with Wroe PC. But there are other clinical trials level 1 evidence that are under preparation right now, and you can expect more proof of the value of proton therapy in the coming years. I'm sorry, there's always some kind of a lag. Okay, then growing number of centers. I think we've all experienced it. This is a small a jump from the past 2010 to what we can see today. And in fact, we went from that number to 179, and that's really a worldwide situation. For innovation, I think, yes, we went from the scattering to AMPT. We brought volumetric imaging at isocenter, but by far, this is not the end of innovation. Dynamic arc is coming up, conformal flash, in the gantry, adaptive proton therapy. I mean, many innovations are in the pipeline and will require more training and more knowledge to the proton therapy community to unleash its power. And last but not least, I think we're in a world that is diverse, and people want to have choices. People want to have options. Options in time frame, option in language, option in configuration, option in cultures, and there are even other elements. But people want to have choice, and people want to be able to manage this diversity to their best, to the benefit of their respective institution. And so those are the 5 elements that drove, this Proton Therapy Academy initiative, because we believe competence drives outcome, and this goes beyond any of us. For us, it goes beyond a specific vendor. This is why we went for a specific Proton Therapy Academy initiative, and the tagline "From knowledge to treatment" when that initiative was launched at PTCOC 2025 in Buenos Aires. Alors, what is it? Well, it's a global hub for particle therapy training and education. It's super accessible. I can only encourage everyone, protontherapy-academy.com. I think that's easy enough to remember. Explore it. There's a lot of content which is free access. It's also a network, and I'm going to talk further of that in a second, but it's a network of 11 top proton therapy centers in the world that came together to bring their expertise together to create training and education content for the proton therapy clinical community. We're also referring many events and many other training opportunities from many organizations, so that for anyone out there, it's easy to access all those opportunities to access clinical training and education content for proton therapy, regardless, again, of where they are, of their time frame, or their culture, whatever, all in one place. And it will only grow going forward, because we know there's a lot of more initiatives in this context that are coming up in the pipeline. I refer to the network members. Here they are, the 11 network members: UMCG, Netherlands, Apollo, India, Corwell Health, USA, PSI, Switzerland, KU, USA again, Quirónsalud, Spain, New York Proton Therapy Center, USA, obviously, IO in Italy, Miami Cancer Institute in the USA again, Mass General as well, and Heidelberg in Germany. And that initiative, through a collaboration, is endorsed now by PTCOC, and we're very proud that PTCOC is supporting this initiative. It's bringing peer-reviewed content. You have customized learning path by role. So being an RTT, a medical physicist, a radiation oncologist, a dosimetrist, a nurse, an administrative, you will have customized learning path. It brings together video and quizzes, and it brings also on-site training at the 11 network members that are listed on this page. That's the QR code. If you want to take your phone quickly, I will leave it for 2 seconds. But again, protontherapy-academy.com. I think that's easy enough to remember to access the platform. Alors, when we were thinking about Proton Therapy Academy and bringing relevant training and education content to the community, we felt that one very important thing was the optimization of proton therapy centers. We're all under pressure. Many centers face pressure to do more with less, more patients with less time. Okay, and so we're launching here Proton Therapy Academy webinar series. Today is the first one. I will introduce what's coming up at the second episode, and it's going to be quarterly. Okay, and it will bring each time 1 or 2 experts from the network members, and they will talk about their experience on how to optimize a proton therapy center. And we want it to be very actionable. So it's really real-world strategies on how to optimize your patient throughput, not a theoretical view, not something that you could consider doing. No, it is something that our network members of the Proton Therapy Academy network have tested, and they're going to share their positive results with us today. I mentioned that it's going to be a series of webinars where we're going to show all the network members. Well, the next one will be on May 26th. You already have the QR code here. Obviously, it will be shared through LinkedIn and social media, but you see that the network member that will be in the spotlight next time is IEO in Italy, and it will be about optimizing proton therapy through hypofractionation, evidence, and early experience. As Jennifer said, please use the Q&A or ideally the Q&A or the chat system of this webinar so that we can take the Q&A at the end of the two presentations that we are going to start in a second now. And the recording will be shared by both the NEPT and the Proton Therapy Academy website after the webinar. And with that, Andrew, the floor is yours.
Thanks very much, Fred. Good morning, everyone. Today we're going to be talking through, or at least I'm going to be speaking on some workflow improvements that we've initiated here at the Miami Cancer Institute, really to drive the efficiency, the use of the system itself. And I'm going to discuss a little bit of the data that we put into practice to evaluate that. Proton therapy, like Fred mentioned, is a unique landscape because we have these centers that are not very common. You know, our footprint is definitely increasing, but it is something where, from a community deployment basis, we want to maximize the usage of these facilities by our patients. We also want to be able to integrate them into our clinics. So here at the Miami Cancer Institute, we have a very comprehensive radiation therapy department with a number of different technology modalities. And what we really wanted to do was be able to integrate proton therapy into that workspace, and not only just integrate it, but maximize its efficiency. For us, we identified 5 areas where we could work on efficiency, and 5 areas where we saw opportunities to improve our own clinical practice. The first being standardization, the second being education, plan development and plan checking was third, work being efficient in the treatment room, and then the 5th being quality assurance. These work have been deployed largely since 2002, 2003. And what we've also done is sought to look at quantifiable metrics to see, okay, is the juice worth the squeeze? Are we getting the best bang for our buck out of these advances? The first step we took was really to sit down and standardize our clinic. And we wanted to build a framework of what is our clinic, what is our clinical practice. So since about mid-2023, we've generated about 180 documents that cover all aspects of our proton therapy clinic. Everything from how do we name our beams, how do we name our plans, how do we name our setup fields, what order do we use our setup fields in, to how do we treat various patients, various disease sites, all the way to how do we do QA and how do we operate the treatment machine in our in-room workflows. Approved copies of these are maintained by the entire system, and they're really built upon by the entire team. These are living, breathing documents that we build on as we see opportunities in the clinic. But what they did is they formed a basis of our proton practice at MCI, and they're accessible at all times through a SharePoint by every member of our physics and dosimetry teams. And really the takeaway was, by defining and documenting standards, we were able to set an expectation. And once we had that expectation, we could build all the other aspects of our clinic. So we could build our encounters, we could build education, we could build scripting. But first we needed to decide, what is our clinic? The next step was to look at competencies. So we've got these standards. We now need to be able to educate our staff in these standards. And so we've driven really a competency-based approach. So training for us is a very, very important thing to make sure that staff know the expectations and then have the skills and understand the processes which we've placed them in our clinic. These competencies can be completed upon hire, they can be completed annually, they can be completed biannually, depending upon the frequency in which we deem that they need to be completed. Another huge initiative which has been done here is that we do have time for staff to go away and do continuing education. And this is scattered throughout the year. But what we do for our on-floor staff, our nurses and our therapists, who oftentimes have difficulty breaking away from their everyday job duties to train, we actually close our clinic for 1 day annually to make sure that they as a team get to take on board educational opportunities and learn about new practices that are coming in or refining existing practices. The real takeaway for us was that educated staff make sound clinical decisions. I don't think that's a shock to anybody, but they do so within a timely manner. So again, driving this efficiency standpoint, if we have staff that know our processes, know the expectation, when they're faced with a clinical decision that needs to be made in a treatment room with a plan, they can do so within a timely manner because they have that confidence behind them. The third step was to look at our processes and to look at, from a physics standpoint, we need to do plan checks, we need to do pre-plan checks, we need to do treat approves. So let's look at that process and let's look at how we can make that more efficient. There's nothing worse than when you're doing a plan check than having to flick back and forth between screens, getting lost, having to search for documents. So what we did is we built our entire process around a refined encounter, which really broke down and had for us available there the documents that we needed to have at our fingertips. If we needed to look at an SBC, we needed to look at a TPD, these were available immediately to us. And then inside of our checklist, we also defined these around, well, how do we proceed through the plan? And we built them around the different tabs inside of RayStation. So RayStation being our treatment planning system. Well, what are we going to check in the patient modeling workspace? What are we going to check in the plan design workspace? We're not having to swap back and forth as we proceed down our checklist. You're able to move to a given workspace, work through that efficiently, then move to the next one. And really the takeaway for this from us was that we had streamlined encounters. They were linked to documentation. This makes checks more effective. It reduces the burden on the staff. And by doing so, it makes them more efficient. The fourth arm was really looking at how we can employ scripting in our clinic. We were very, very fortunate in 2023 to be able to fully employ a computational physics associate within our team. And in doing so, what it meant was that we had a resource through which we could build scripts we could work with while not taking staff away from their clinical duties. Now, the first level is that we can have scripts handle those very, very mundane tasks, alleviate some of the pressure off the dosimetrist. So beam naming, setup beam generation, QA plan export, those sorts of things inside of the treatment planning system are very easily scriptable, and they're things that we can, in essence, drive efficiency with. We can also look at employing it in plan checks, and this is an example of one of our plan check reports, where we are able to check those standardized items, whether it be what are your overrides? Are your override structures named correctly? Is your plan named correctly? Is your beams named correctly? Are you using the correct grid size? These sorts of things are very, basic checks that now that we have a standardized framework, we can very quickly and easily run this script, highlights green if it passes, red if it fails, and at least is able to then draw the physicist's attention to concerns with the plan. We then upload this to our OIS so that we then have a record of the checks that we did. One area that we've identified as a need to improve on or work towards for us as a clinic is that our plan check scripts only check the plan inside of Wroe currently. What we export to the OIS is then manually verified. So for us, aura-based report checking is the next step in our clinic. And we've we've built a system following the guidance of TG 275 and 315 to look at how we can evaluate not only the plan itself, but also what has been exported to that OIS. And we have a system right now, which is in its testing phase, that is checking over 50 parameters between both systems, alleviating that burden on the physicists to be checking these rote things over and over again, allowing them to focus time on the plan itself and the clinical aspect of that plan. For those of you who have interest, I do encourage you to meet with Dr. Semenuk, who is leading this work at our institution. He'll be presenting it at PT Cog. From a scripting standpoint, I think the biggest takeaway is that we need to invest in letting computers do what computers do best, which is these repetitive checks and these transfer of data. We want staff to be able to focus on clinical items of importance, and in doing so, we're driving efficiency. So for us, as a physics team, we've implemented these changes in our clinic, and the next step was to assess the impact of these interventions. So we have 6 care paths that are active at Miami Cancer Institute for Proton. So we have our standard, our expedited, and then we have some more boutique ones, our urgent CSIs and our grid. Each of them have these common tasks in there for physics, whether it be a pre-fusion review, a pre-plan check, a plan check, a QA, or a treat approve. And what we wanted to do was look at the care path completion times to see how did these change over time. And for us, we've gone through a lot of change since 2017, since the center first opened. And what we see is that as we implemented each intervention, our workflows became tighter. There's less variation. There's less person-to-person variation. There's less plan-to-plan variation. And we're driving things faster and faster with this expectation of achieving the care path on time and on target. And so through here, we enforced our compliance with care paths. We overhauled our checklists. We overhauled our planning techniques. Here in 2022, we actually decreased all of our care paths by 2 days. And in 2023, we implemented our ARIA enhancements with encounters and checklists, again, another revision, and we got faster again, and we got tighter again. And so this to me shows that the things that we're implementing are saving us not only hours, but days in our care paths. And while we were doing this, we were actually growing the complexity of our treatment planning process. So we were implementing in 2021, robust eval and optimization was standardized for all disease sites. January 2022, we implemented a 5-day care path for urgent CSI cases. By March, all plans with the exception of prostates were being optimized and calculated with Monte Carlo, and by 2023, all plans were being calculated with Monte Carlo. So we're introducing these complexities to our treatment planning process, which should, in essence, be driving times longer, but in effort, we're actually driving them to be faster through the other gains that we're doing in our clinic from an efficiency standpoint. I think the takeaway here was that our standards, training, encounters, and scripting allowed 2 days to be saved from our care paths, and this is just the beginning for us. Here's a paper by Dr. McConnell that was presented in Advances in Radiation Oncology, if you would like to read more on this work. Our next goal was really to look at our in-room treatment times, and we did this by looking at a real-time location tracking system, which was implemented in our clinic during COVID, but with which we were able to look at tracking our patients as they move through our space. And it's done through these Care Connect badges. And what we're able to do is we're able to see how long patients stay in various rooms, whether that be treatment rooms, whether that be CT sim, whether that be waiting rooms, or various exam rooms. And it provides us an unbiased method of seeing how long are they staying there and where could we improve. And so for us, what we did is we looked at the treatment times across various disease sites, broken down by gantry, and you can see down here the fractions that we were able to track over a period of time. And what we're able to see is that most of our gantries are fairly uniform in how they treat some of these common tasks. We do see that there's a big variation, for example, in the number of fractions of certain disease sites being treated in certain rooms. So, for example, here, lung is being treated almost 2.5 times more in gantry 3 than in gantry 1, just simply because gantry 1 is used for anesthesia. But largely, that's not driving an efficiency inside of that treatment room. What this did prompt us to do was to look critically at our in-room workflows and look at how we could change our practice. We identified a number of improvements that we looked at in 2024, the key of which was kind of going back to utilizing skin marks, utilizing CRAD, using that surface guidance to be able to get the patient in a better pose before treatment. And this would then reduce redundant imaging, and it would get us to a position where we relied less on just simply placing the patient on the table and then relying on imaging and the 6-off couch to get us into a great position. We were able to position the patient better up front. We used 10% isodose line for evaluating tissue on cone beams. We developed specialized RTT treatment teams for specialized cases such as APBI, GRID, CSI, where these staff had additional training. And then we looked at overhauling our encounters so that our encounter kind of proceeded through what the therapists were doing. What are they doing before they bring the patient back? What are they doing before irradiation? What we were able to see was that for, say, for example, our urgent CSIs, we changed from having an average treatment time of 57 minutes with a variation of 30 minutes down to a treatment time of 49 minutes, so 8-minute gain per patient per fraction, with a 9-minute, 10-minute variation in any given fraction, which is a big gain. The big one here was using those skin marks and having a specialized CSI team treating those cases. Across our broader treatment sites, we were able to see that CNS gained 5 minutes, head and neck gained 10 minutes per fraction, CSIs 18 minutes, and breast 5 minutes. And breast is an interesting one because at the same time that we did these improvements, we also implemented daily cone beam for these patients, which was fantastic. So we increased the complexity of the imaging while it's also decreasing the treatment time. This led to us saving about 1 to 2 hours per day per room in Proton clinical operations, which really rolls out to being an extra 2 to 4 patients per room that you can treat. Again, the takeaway is these interventions did allow for significant gains in treatment efficiency. Again, if you'd like to read more about this, there's more information on the International Journal of Particle Therapy. Again, Dr. McConnell published a really excellent paper outlining the work that we implemented here at MCI. Just lastly, real quick, we know that quality assurance does eat into clinical operation time, but it is essential for us to be able to really ensure that we are delivering radiation to the highest quality to our patient. So for us, we looked at how can we implement a more efficient program. We did so by defining a clear framework of tests within a controlled third-party software. This allowed for our tests and equipment to be controlled. We automatically interfaced our tests with our measurement devices, and we had a clear indication of passing results. So what this did was it allowed us to be very efficient in our work. Being efficient doesn't mean that we necessarily have to be less thorough. And at the same time, we implemented various graphical tools that allowed us to evaluate whether that's spot sigma or whether that's collinearity, and see very, very clearly outside of those tables of numbers over and over and over again, but allowed us to see trends and dig into things offline while minimizing our footprint inside of the treatment room. So I would say the takeaway there is that QA can be thorough while also being efficient. The two are not mutually exclusive, and that driving efficiency in QA does open up real clinical operation opportunities inside of the clinic. So, and with that, I will pass on to Dr. Simone. Thank you very much.
All right, great. That was terrific. We've looked at some of the same efficiencies and some others that we'll talk about today. So nice to talk with everyone. Well, Disclosures are NIH funding. Yeah, why have we needed to be efficient? Well, most days we're the busiest center in the US. We're treating now in the 120s pretty consistently. We're up to 130 a day in 3 gantries and 1 fixed beam room. So, high throughput that we need to do. And of those patients, we have a very, very complex case mix. We're treating more hemithoracic lung patients or more IMN positive breast patients than really any other center with protons. As those of you know who treat those, they're very, very large volumes. They take a long time to treat on the treatment table. Similarly, we have a very large liver experience with high doses per fraction, a lot of SBRT for very large volumes of liver. So all of those take quite a good bit of time to get through. We also, have really the highest SBRT volume. While nationally only 1% of proton courses are SBRT, it's about 15% of all the patients that we treat here. SBRT, of course, with higher MUs, more need for precision, physician and physics checking each day before treatment. Those treatments take longer. And then similarly, we really have such a high reirradiation volume, nearly half of all the patients that we treat, relative to the national average of 15%. And most of those reirradiation patients, we commonly do an extra field more than what we would do otherwise. All of these make it that we really don't have a lot of short, simple treatments where we can kind of quote pad the schedule and catch up if we're running behind on a schedule. So it's really been critical that we've tried to optimize efficiencies as much as possible. Certainly everything that I'm going to say, applies to a single room center where you're struggling to be at capacity as well. But we really do live at capacity, and so we've kind of thought through ways to reduce time. The first thing that we've done, looks like we skipped this slide. Okay. First thing that we've done is looked at the number of treatment fields. This is pretty intuitive, but we have a really great dosimetry team, and sometimes so great that they spend an extra 2 days and an extra field trying to reduce the parotid mean dose by 0.4 gray. So something that's probably not clinically meaningful, but certainly a plan that dosimetrically looks a little bit better. But in looking at that, there may be fields that are delivering only a handful of MUs. There may be an extra field that wasn't needed in the first place to get to that point. So what we said is any patient that has more than 5 fields, that plan should be reviewed by our director of medical physics. And any field that has less than 10% of the total MUs being delivered, we would essentially rerun the plan and try to see what the dosimetry impact is if we take that field off altogether. And in short, if there's not a dosimetric impact either way, then we would recommend proceeding without the extra field. Each field takes on average at our center across all disease sites around 7 minutes of in-room treatment time. So, if we could save a field on some of our patients, that's a real meaningful impact. In 2022, this is where we put, the first several years we were open, 2019 is when we opened, we worked on efficiency as far as setup and things like that. Really, these operational efficiencies we put in place in 2022. So comparing 2022 to 2025, we treated in 2022 nearly 1,200 patients. 11% of them had 5 or more fields. Now it's about 8% of our patients have 5 or more fields. Doesn't sound like a big difference, but if you think about a 7-minute improvement in 2.5% of all the patients that we're treating, we're essentially able to treat one more patient a day because of this. Again, we're being very judicial in who we're actually removing a field for. That's 5 or more fields. Same effect you can see here for 6 or more beams, also a reduction over the years. Similarly to thinking through removing fields, we've had a slow rollout of alternating treatment fields. Again, if we're saving 7 minutes per treatment field, can we, instead of treating all fields in one day, decide not to treat some fields? And some centers on this call probably are already doing this for your prostate patients. If you're getting opposed laterals, some centers will treat the right lateral one day, the left lateral another day. Obviously, a great way to optimize efficiency. We've not taken that approach yet. We've been a little bit more conservative in that we wanted to really study the effects of the high LET if you're having all of the dose in a given day, end range and deposit in a single area. We've been a little hesitant to roll that out. But what we said is if you have 3 or more beams, that is something that we would consider removing a beam for. We've been even more conservative in that we said it has to be 3 or more beams and it can't be a reirradiation case where the OAR risk may be a little higher. It can't be an SBRT case where we're delivering higher MUs that could all end range in the same area. And it's hard to keep track of in an MFO environment as opposed to an SFO environment. But if you use all those restrictions, about a quarter of all the patients we treat could be eligible for this. We haven't done this in a quarter of our patients yet, but certainly the opportunity to grow this program exists. And if we can save 7 minutes on a quarter of our patients, that could be clinically meaningful. Minimum MU is an interesting aspect as well. So we've taken the approach of trying to remove clinically insignificant MUs, and in doing so, it can save a few seconds to even up to a minute per beam per patient throughout the day. So we wrote a code that allows us to increase the threshold to automatically remove spots with a limited number of MUs across our 2 different treatment planning systems that we use. And we really customize what that minimum MU parameter is based on the size of the target volume, the number of MUs per fraction, the dose per fraction being delivered. So we have different algorithms of different disease sites, but in essence, if we have very, very few MUs in a spot, we're removing those MUs in the treatment planning process. And in doing so, if we're saving 20, 30 seconds per patient per beam, it adds up to around 10 or 15 minutes per treatment room per day. So across our 4 rooms, we're probably treating around 2 extra patients because of this initiative. SDX has been a big focus. We use this for motion mitigation in our thoracic and upper GI patients, for anatomical benefits in our breast patients. This is a form of breath hold. We generally schedule all of our patients in 30-minute treatment slots, with some exceptions for SBRT and other. For SDX, though, in patients doing breath hold, we schedule them for 45 minutes. And even that, historically, we've had some trouble even meeting 45 minutes. We know there are some outliers that can take up to 60 minutes if they're having trouble holding breath or following the instructions. We've generally used a threshold that said, which many centers do, you have to hold your breath for 25 consecutive seconds to be a candidate for SDX, and generally do that for 3 to 5 consecutive times, being able to hold your breath for 25 seconds. What we found is some patients can do that on day 1, but as their treatment goes, where they have more fatigue, more complications from radiation or chemotherapy, they're not able to hold their breath as well, and it's become more challenging and slowed down the ability to proceed. So we've changed our threshold from 25 seconds to 35 seconds to be able to hold the breath, and we've had more scrutiny for some patients that are elderly and may have more trouble holding the breath to really evaluate if it's a feasible option for them. Beyond that change, we've also looked at our breast patient population specifically. Historically, when we opened, we were doing STX on all of our breast patients. We've now essentially discontinued all right-sided cases or bilateral cases, unless there's a clear need or anatomical abnormality that we would find a benefit for it for. We still are doing it for left-sided patients, but we're not doing it indiscriminately like we were before. Now, in real time, at the time of every simulation, we have a physicist and a physician go down to sim and essentially evaluate what is the anatomical difference, where is the heart moving, where is the lungs, etc., when patients are having a free breathe scan versus an STX scan. And if we see there's greater separation between the breast and the heart, we would proceed with using STX. And if there's not, we would use free breathing. So obviously it saves patients stress, but certainly saves us time on the treatment room. And then for other disease sites, we put in some conditional guidance. If it's a palliative case, we generally would not recommend STX. For SBRT, where they may have long breath hold, long treatment times, or BID cases that are long time on the treatment table as is, really have more review and make sure that there's a benefit to STX. So instead of just, for motion cases, going right to STX, maybe looking at what is a 4D motion assessment, what is the compression assessment, and then what is the STX assessment, and making sure the STX actually can be a benefit to the patient. So how has that helped us? Well, we now are treating quite a number of breast patients. As our 3rd busiest disease site. We treated 125 patients last year. Slower ramp early on, and by the way, essentially all of these 99% are comprehensive IMN positive patients. We aren't really treating partial breast patients here, but when we treated in 2022, before putting this in place, 37% of all the breast patients we treated with STX. as we were slowly rolling out limitations on STX use. Now we become much more methodical, much more judicious. Only 10% of our patients are getting STX. So at the same pace that we were doing in 2022, we would have treated 34 more patients last year with STX. As you can imagine, if we're saving at least 15 minutes per patient per day, 34 patients definitely do add up. And it's not just breast patients. Here you can see that, excuse me, it's while breast has been a reduction, we're reducing it for some of our thoracic and other patients as well to be able to reduce time on the treatment table. One initiative that we've been much more loose about is multiple ISO centers. So we know that by treating more than one ISO center, it can add 18 up to even 45 minutes, depending on if it's an SBRT with STX. So what we've said is we really want to make sure it makes sense that we're treating multiple ISO centers. For any patient that has 3 or more ISO centers, we should have peer review and CMO approval. For patients with 2 or more ISO centers, but long treatments, so 2 sites with STX, 2 sites with SBRT, similarly have physician review and approval. It's not that we aren't approving these, but we're being a little bit more knowledgeable about the impact that it has on patients. So for instance, if we're treating 3 sites with SBRT and STX, that patient will literally be on the treatment table for 2 hours. If our physicians knew that a priori before the patient got on the table, they may have made different recommendations in their plan. So, we want to be aware and make sure that the treatment's going to be feasible for the patient. Despite putting this effort in place, we actually are treating more ISO centers today than we are in 2022, but really just a mechanism of the complexity of patients that are being referred. One big initiative we've had is to try to really increase our utilization of our gantry room, as our fixed beam room. As I mentioned, our 3 gantry rooms are essentially always at capacity 100% of the time, 100% of the days. Our fixed beam room, however, is not. We generally are treating at about 80, right now, about 85% capacity in the fixed beam room, but we certainly can treat more patients than we currently are. That's really the only way our center can expand above that 130 cap that we really have right now. So it's been a priority to be creative in how we've done that. We've talked before at the NAPT annual meeting last year and previously about our use of treating CSI patients in the fixed beam room. One easy one is prostate patients. So when we opened, we first commissioned our gantry rooms. We were treating all of our prostate patients in a gantry room. As soon as we commissioned our fixed beam room, we immediately moved our conventional and mild hypofractionated prostate patients with fiducial markers into the fixed beam room. But we still were treating our SBRT cases, our cases without fiducials in a gantry room. We shifted those in 2022, and that's meaningful in that over half of our patients that we're treating with prostate cancer are SBRTs. If we're now able to treat those in a fixed beam room, that's a big savings. Even patients now without fiducials, we're treating in the fixed beam room. We're using a bladder scanner to assess for bladder fullness. We're using a CT scanner outside of the treatment room to assess for anatomical and bowel filling. But it's worked quite well to the point where now we've essentially treated or will treat about 50 extra patients a day in our fixed beam room with prostate cancer alone than we were before. And that's meaningful because those are patients that would have otherwise taken a gantry slot that now can be safely and methodically treated in our fixed beam room. Add to this over 50 patients a day that we're treating with CSI treatments in our fixed beam room, and you can see a growth of about 100 patients just from those 2 disease sites, saving gantry space for other patients. One neat initiative is invisible ink tattoos. We ran a clinical trial, the preferred trial, looking at an evaluation of patient-reported outcomes for patients receiving invisible ink tattoos. You can see here it's visible with black light, but really not visible to the naked eye. We have many patients in New York that either for religious reasons don't want any tattoos or have very strong opinions about anatomy and having visible ink tattoos. So for those patients, we were historically using just marks and tape, but that can be complex. You can have problems with showers and other things. For large treatment areas like a CSI treatment, if those marks are not perfect, it really can take a lot of extra imaging and a lot of extra in-room time to set a patient up well. So we assessed patients' preferences for visible ink tattoos, invisible ink tattoos, or no tattoos. Clear and away, invisible ink tattoos were the strong preference of patients. They're willing to travel further to a radiation center who had it, pay more money even to get it. And what it meant for us is essentially a lot of in-room savings time. So time in the room and on the treatment table was shorter. Average time from first beam to treatment, total treatment time, and average treatment time, all a couple minutes less when we use the invisible ink tattoos. So we don't need this, of course, for our mass patients. The mass are indexed, so our primary brain and head and neck, not so. But for all of our other patients that we were not doing tattoos at all before, invisible ink tattoos are saving us about 2 minutes per patient. So that's been meaningful as well. And then close to finishing up, this is looking at how we've changed with our treatment planning system. This is just one example, but craniospinal treatments, when we were treating these patients in Eclipse, we were treating on average taking about 32 minutes. In RayStation, they're treating and taking about 27 minutes. So faster treatment delivery as well as more robust treatment planning has been helpful to us. So the TPS is saving about 5 minutes for those patients. We're seeing some savings for other disease sites, breast, for big comprehensive treatments, about 4 minutes. But if you look at the CSI example, for instance, the treatment planning system alone is shifting longer treatments to shorter time. Why this is meaningful, we're treating about 100 CSI cases a year. It's about 8% of all the patients we treat. They're usually long treatment times. If we're saving 5 minutes per 100 patients per day on just the treatment planning system, then when you add the invisible ink tattoos to this patient population, in those patients, we're saving about 7 minutes, not just 2 minutes, because the time that it takes to align what's often 3 isocenters in these patients is much longer. And we're also being more thoughtful in our patient selection of CSI. A lot of the original work on leptomeningeal disease came out of the New York Proton Center, Memorial Sloan Kettering, and Procure, New Jersey. So our docs were very proactive and said we should treat all of our leptomeningeal patients with CSI. But we've seen pretty quickly that the ECOG performance status 3+ patients, they're not really benefiting. And those are also the same patients that have a tough time in the treatment room, tough time setting up. When we've been more judicious with our patient selection, with our use of invisible ink tattoos, and with our treatment planning system, we're saving about 15 minutes per patient for CSI, which is a big, big deal for us. We're now treating these patients essentially in a regular treatment slot and not needing a longer treatment slot. Then the last initiative is how we schedule. We've installed monitors into each room so everyone could see what everyone else is doing. This is just one example. No patients on the images for HIPAA purposes, but one of our rooms could see all the other 3 rooms, where our patient is, are they imaging, are they treating, etc. Not just relying on requesting priority for the room. So if a room knows that their next field to be delivered is a short, quick field, low number of MUs, there's not a big couch kick, so they could get to and rotate to the angle very quickly. We've encouraged them, if other patients aren't immediately waiting, just request priority and treat that field immediately so that patient could get done and get off the table while the other patients are still setting up for other things. So having that increased visualization has really had a big benefit. It's saving probably on the order of about a minute to a minute and a half per patient, which really magnifies throughout the day. So a very simple solution that has been a big time savings. And related to that, we've also color coded. You can see we have about 20 different colors on our schedule, probably a little excessive, but everything knowing if it's a new start, a cone down, an SBRT, a pediatric patient, if it's a chemo patient that can't be moved, SDX. So other people know what other rooms are treating and knowing how to request priority accordingly. So our future direction is simply, we started this with machine learning and now using AI, really trying to, almost like a game puzzle. If we have 130 patients that are scheduled, we know how many MUs are in each field, how many fields they have, what angles those fields are. How do we rearrange a schedule to be as efficient as possible? And this is ongoing work. We don't have a perfect solution yet, but we're trying to study this in addition to taking, of course, into account patient preference for time of day to see if we can optimize treatment. And there's no way to be more efficient than Flash, so this is a big focus of our center. If we could change 5 weeks of treatment, 10 minutes of beam delivery time to just a single day, less than a second, of course, that's going to be a huge win for our patients. So hopefully that's the future of our field. So in conclusion, we've really increased our gantry time pretty significantly, whether it's through scrutiny around the number of beams that we've used, selectively enacting alternating beams, increasing our minimum MU per spot thresholds, being more judicious with STX use, thinking through the number of isocenters that we treat simultaneously, shifting cases like prostate SBRT and non-fiducial cases or even CSI cases to our fixed beam room, use of new treatment planning system, and then how we schedule and visualize other rooms. All of that together, we're treating now about 10 more patients in the gantry a day today than we were in 2022. And that was already when we thought we were kind of as efficient as we could get with setup and therapy education. So it's really been a big savings for us to be able to enact these important initiatives. That's it. Thank you.
Okay. Thank you so much, Dr. Simone and Andrew. May I ask you to power your camera on, Andrew? Yes, excellent. So thank you so much. And we have several questions in the Q&A. So I'm going to use, we have, 10 minutes left. Great. I will start with you, Dr. Simone. Question is, by mandating the removal of those less than 10% weight field to save 7 minutes of in-room time, what is the potential impact on plan robustness? In parentheses, the plan's ability to maintain a safe dose despite patient movement or setup errors. Is the 7-minute gain in efficiency worth the potential loss in dose homogeneity?
Great question. And to be clear, it's not a mandate. These are all suggestions for how we can improve efficiency. So if we see that a field has less than 10% of the MUs, but it's of value in reducing OARs, improving coverage, we will absolutely keep it. What we do is we essentially take that exact field, we rerun the plan without that field, and we overlay the dosimetry and say, what is the effect by adding or not having that field? And if there's a benefit, we'll keep it. But if there's not a benefit, we save 7 minutes, which, of course, magnifies and can improve the number of patients we treat, but more, it's less time on the table for a patient, less anxiety as well. And these are all cases where they're already probably having 3 or more fields in addition to that low-weighted field. So we aren't seeing a concern since we're doing it very judiciously.
Thank you, Dr. Simone. I will go to Dr. Wroe. Have you seen any efficiency downsides to increased CBCT usage?
No, we haven't. I mean, we're using daily cone beam essentially on every disease site, with the exception of intact prostate and some CNS cases and CSIs. So across a large number, I think combined with the use of the skin marks, the surface imaging that we have in place with our surface imaging system to get patient pose correct. And then really employing, which I know a number of other centers do, the 10% isodose line to allow a structured tiered alignment structure mandate for our therapists. It allows them to very quickly evaluate that cone beam. And I think that's largely been what's driven the fact that we haven't seen a big negative impact on our clinic.
Thank you, Dr. Wroe. I will ask the next question to both of you. Would you be in a center that just opened? What is your top 1, 2, maybe 3 max, your 1, 2 top initiatives you would first implement to improve efficiency?
I can start. I'll say nothing that I presented today, actually.
Okay.
Everything I presented today was more, we've been open a little while. We thought we already got very efficient. And now what can we think through? I think the number one thing is therapy training and education. Them being comfortable with setups, being reproducible with setups. I remember we hired a very experienced therapy team, including bringing on a lot of therapists from other proton centers. But even still, if you look at the number of KV images that were taken in our first few months of treatment versus where we are now, it's day and night different, which of course is exposure to patients, let alone time on the treatment table. But having a very good, very well-trained, very experienced therapy team makes a big difference. The other important initiative related to that is simulation. And we still, to this day, now almost 7 years into the center, for every simulation have a physician, a physicist, and a dosimetrist go to sim, which sounds like overkill, but this is not a VMAT world in photons where if you don't have a perfect sim, you just put an arc around something and you can easily make up for it. We want it to be incredibly reproducible. We wanted to think through every potential challenge that could come up and have the ability to have what beams that we want to deliver already identified at the time of sim, so we can make sure that it's going to be reproducible, that we can deliver those beams. And so we've really made a priority of making sim as rigorous as possible. And that really translates. If sim is not reproducible, you're going to kind of torture yourself for the next 5 weeks of treatment and trying to get that patient in the right position.
Yeah, and I would just echo with what Dr. Simone said. I mean, I think for us, if you're looking at a brand new center and you're onboarding, making sure that your treatment teams are aware of the standards, defining those goalposts, whether it be sim, whether it be with plans, whether it be on the treatment floor, I think is very, very important to have clearly thought those out and think out how we want our clinic to be structured and how we want, for example, our mobilization. If you have some very clear understanding of how you want your patients immobilized, and you have some very clear understanding of how you want that patient to be planned, and then how you want that patient to be treated, you can then effectively take the next step, which is training your staff. So I think those are the two areas where I would say that for a new center opening up, defining those standards, making sure that your staff are very well trained and comfortable with those standards. And then out of that, you can define what we've done. We've defined some specialized teams. So you've got a specialized SIM team, you've got a specialized CSI team, so that you know those therapists that are very comfortable with different aspects of treatment. You also know your dosimetrists who are comped on various plans which they're creating. And I think that's largely going to drive efficiency for a new center and set you up in a very good spot to move forward.
Thank you, Dr. Wroe. Dr. Simone, I have two questions for you around SDX, and they go a bit in different directions. One of them is, okay, by moving somehow, what were the objective criteria you used to decide which patient would move away from the use of SDX during their treatment? So that's one question. The other question is, okay, even if with SDX, the fraction time is longer, but you can maybe hypofractionate more, then maybe at the end it is still a win. So what's your perspective on those two questions?
Yeah, great questions. We generally, for breast, for instance, where we're doing it for anatomical purposes, we're generally not hypofractionating off of a trial. We actually have a randomized trial looking at comprehensive nodal irradiation for breast, randomized to hypofrac or conventional frac. Many of our other breast patients are re-irradiation, and we're generally not hypofracking those as well. So we're really using it, SDX, not to help us hypofrac, but to really have more separation between the heart and the breast itself. For our liver, for our lung, absolutely. And most of our liver volume now is SBRT as opposed to hypofrac, and certainly not conventional frac. And STX is a big enablement of that. So most of our liver patients are getting STX. The point for the motion patients, though, is if we see that a 4D, there's very little motion, or if that motion could be very successfully mitigated with an abdominal compression, and that abdominal compression is not interfering with the treatment in any way, that's a lot easier on the patient to tolerate. So it's not just an operational issue at that point, it's a patient comfort. And so, that's the route we prefer to go. We've been very rigorous with testing and assessing. For instance, for breast, we've done a lot of study, a lot of presentations on and papers on what is the actual dosimetric impact, and the answer is very little, quite frankly. Proton therapy, probably less magnitude of benefit to SCX than IMRT is, but if you deliver proton therapy well, we can avoid the heart to a good extent. Now, of course, if we see that there is a benefit, and that's why we literally have for every single breast case now that's a left-sided case, a physician and dosimetrist evaluates in real time on the table what is the separation to the heart. Based on the number of patients we've treated, we know that separation equates to how many centigrade of extra dose to the heart. And if it's more than literally just a couple of centigrade, we'll use it. But if it's not, then there's no need to put patients through that kind of torture. Myself, I'm a thoracic radiation oncologist, not just the medical director of a center. So I certainly love using breath hold and other techniques like that, but I'm also mindful that my patients don't love it. And so if we don't need to use it, we don't want to use it.
Thank you, Dr. Simone. I see we have 1 minute left, and there's a few more questions. We'll try maybe to send emails or messages. I will ask maybe just to Dr. Simone and Dr. Wroe one more very quick question. Did you present anything today that is not in reach of any proton therapy center? I guess that's question number one. And then question number two, do you see Proton Therapy Academy playing a role in implementing those efficiency improvement initiatives? Dr. Wroe?
No, I definitely see that everything we've done, and certainly the things that I presented, are things that are achievable. They're things that are just basically common sense, looking at different ways to do it, building on other people's experiences. So it's not something, there's not something here where we've redesigned an entire treatment machine or that. It's looking about practical solutions to driving proton therapy efficiency. And some of the ones which I presented in my talk are ones that are already adopted and which we learned from other centers that is not MCI. So I definitely see that being a benefit. And that's where I see the Proton Therapy Academy coming in, is that allowing this sharing of knowledge and allowing this transfer between centers ultimately allows you to then see really at the grassroots what folks are doing, and allows you then to somewhat be able to then question and challenge your own clinical practice and build on that.
Yeah, I'll just a quick 20-second add on. 100% agree. I mean, some of the things that I said about may not apply if you're not a multi-room center or if you don't have a fixed beam room, but everything else can be taken immediately and put into clinical practice. And I do think the Proton Therapy Academy, yes, it's what is the data for protons? What are the indications for protons? But efficiency is a big part of it. We right now are only treating about 2% of patients that get external beam with protons, but maybe that number should be 20 or 30% based on clinical benefit. And so how do we increase the number of patients we're treating? Efficiency is critical, and I think the Proton Therapy Academy can really help with that.
Okay. Well, oops, went too fast. Okay, thank you so much, Dr. Wroe, Dr. Simone. I think the webinar was great. We shared a lot of insights on how you have improved the efficiency of your respective centers. I really hope it was insightful for all the audience, and I want to thank again NAPT for facilitating and helping us setting up this webinar. So Dr. Wroe, Dr. Simone, thank you so much. Have a great day all, and see you at the next webinar somewhere in May. You will all receive an email on how to register. Thank you so much, and bye-bye, everyone.